Hello. Today's lecture is about the opioids, and this is another lecture in the neuroscience pharmacology. And this class of medications is very important in some diseases and conditions that are very common in the clinical environment. And to give you an idea, a very brief explanation of the importance of these class of drugs, we can see in the left figure I'm showing here a person who looks like suffer from pain, and these medications are important in reducing pain in patients. They are very strong analgesics. And on the right side of the slide, I have a picture of pills that arranged in a picture of a clock, and that clock is showing the 10:10. So because the 10:10, we can see it gives us the smiley face, and these medications that can produce happiness to the people who take them, and that's a condition called euphoria. So this medication are very important to reduce pain, but at the same time, because of their euphoric action, and they are may produce something called addiction. So today we will talk about this important class in the clinic. To start with, we need to talk about the sensations that we feel in the human body, and I'm sure you know probably more of this information from the anatomy and the physiology lectures. So sensations in our body include touch, crude or fine touch, temperature, hot or cold, taste, that's especially in the oral cavity, pressure, as well as pain. So pain is one type of sensations we feel in our human body, and pain itself is um, classified into multiple types. It can be classified in according to its severity into severe, moderate, and mild pain. It can also be classified according to its duration. So if it's duration for a short period, we call it acute. But if the duration is too long, weeks or months sometimes, and sometimes years in some conditions, that may be chronic. And there is a special type of pain that is called neuropathic. And from its name, that means there is a pathology in the nerves themselves. And this sometimes is class or subclassification of the chronic types of pain. And this is a very hard to treat, the very hard type of pain to treat, and it is very annoying to the patients. And examples of such conditions that produce neuropathic pain are, for example, diabetic neuropathy, or chemotherapy-induced neuropathic pain, or people who suffer from phantom limb pain, which are patients who loses their, for example, one limb, for example, upper limb or lower limb, and the patient still suffer from pain in the amputated limb. So there are multiple types of sensations, there are multiple types of pain. Now this lecture is specifically talking about drugs that are used to treat pain, so we'll focus more about pain sensation. So what is the definition of pain? Pain is unpleasant sensory and emotional experience associated with actual or potential tissue damage. So the importance of this definition, which has been around for probably now 40 something years, since 1979, from the International Association for the Study of Pain. They use this definition, and they cannot find any better definition to define pain. So the key words here, I want you to look at the emotional component. So it's not only sensory component that the patient may suffer, but also the presence of pain may be reflected on some emotional behavior changes. And such emotions, for example, the patient stop enjoying, for example, watching sports, or stop enjoying food, or stop enjoying having good relationships with his family. So both emotional as well as sensory component. So this is number one. And number two, if you look now, that pain can be associated with actual damage. So there is an actual injury to the tissues, to the skin, for example, or to the bone. So there is an actual injury. So that's actual. Or potential tissue damage. And here we say potential because in some conditions, the patient may come to the clinic suffering from one type of suffering from pain, but when you examine the patient, you cannot find any sort of injury. And that kind of that's what is meant by the potential tissue damage. And a big example of such potential tissue damage are patients who suffer from what just talked about, for example, neuropathic pain or diabetic neuropathy, where the patient who is diabetic and he's suffering from, for example, numbness as well as pain in his peripheries, in his hands or his or her legs. So that's kind of, we don't see any damage, but still the patient suffer from pain. So that's why in the definition they added a potential tissue damage. Now it is very important at this stage to differentiate between two definitions. There is an analgesia as well as there is an anesthesia. There is a major differences, and probably you know this by now. So analgesia is the blockade of sensation of pain specifically without affecting other sensations that we talked in the previous slide. Anesthesia, on the other hand, is the loss of sensation in all types. So the loss of pain sensation, the loss of touch, temperature, or pressure sensation or taste sensation. So anesthesia is losing all sensations, including the pain. So we can summarize that anesthesia is all anesthetic can be analgesic, but not all analgesic are anesthetic. And this is important differentiation. We will have a lecture about local anesthetics as well as general anesthetics. Again, in this lecture, we will talk about opioids, which are classified under the analgesic class of medications. Now, also at this stage, I want you to understand the definition of paresthesia. Paresthesia, which is abnormal sensation at the skin, where the patient may suffer from tingling and pickling sensation. The patient may feel that there is needles that are inserting in his skin. So it is a weird sensation, it's an unpleasant sensation, and that's called paresthesia. Okay, now you probably know by now the pain pathway. So in this figure, we have a simple graph showing the major sites or the major pathway for pain. So let's assume that this is in the periphery, and there is a stimulus here that producing pain. So we have neurons here that are called nociceptors. There is another name for those nociceptors. They are called first order neuron because they are the first neurons to feel pain in the periphery. Once they are activated by the presence of pain, and we have many types of nociceptors, and I'm sure you took them in the physiology or the anatomy. There are some nociceptors that are specific for temperature, some nociceptors specific for any chemical problems, some nociceptors of cold temperature, some of them heat temperature. So many types of nociceptors. So once they are activated, they will send signals toward the central nervous system. And here, if you were talking about the periphery, lower than head and neck, we are talking about going to the spinal cord. In the head and neck region specifically, it goes to the brain stem directly. So the first order neuron or the nociceptors send the signals here. They enter the spinal cord through the dorsal horn, and they synapse with another neuron, which here we're gonna call the second order neuron. Now this second order neuron now will receive the signal, and then it crosses the the midline, and then it runs in the spinothalamic tract up to the thalamus. In the thalamus, they will synapse. It's not showing here though. They will synapse with another neurons that we call third order neurons that goes to the primary somatosensory area in the brain, or Brodmann area, I think 1, 3, and 4. And once the signals reaching the cortex, in that case, the patient will say, okay, I'm suffering from pain. Now, another important thing that this figure shows, which is something called the descending pathway. So one good thing about the ascending pathway is that while it's running toward the thalamus in the second order neuron, it will send another synapses to another areas in the brain. Some of them will go to the amygdala to provide some emotional component. Some of them will go to hippocampus for learning and memory, and some of them will go to another area in the brain called periaqueductal gray, which I hope you took them in the anatomy and you know the function of the periaqueductal gray. Now this periaqueductal gray then sends signals to another area in the brain, although it's not showing here, the rostroventral medulla, and eventually this collateral pathway, or what we call descending pathway, will send the neurons down to the synapse between the first and the second order neuron, and it will release neurotransmitters that will decrease the transmission of the signal from the first to the second order neuron. So the sequence of events is that the first order neuron will get activated by pain. It will send the signals to the second order neuron, and second order neuron, when it goes to the central nervous system, to the higher centers in the brain, it will send signals to another areas such as periaqueductal gray that will go down and inhibit the transmission of signal here. This is an endogenous system that's built in our human body, where it provides analgesic it will provide analgesic feeling during acute episodes of pain. And you probably think about it when you hit something very hard. Initially you have a huge pain, and after a few seconds the pain will go eventually, and that is because the function of this descending pathway. Here's another figure showing the same thing. We can see this is the first order neuron that sends signals toward the central nervous system. You know, this is the pseudo-unipolar neurons, where it has the cell bodies in the dorsal root ganglion. It enters the spinal cord from the dorsal horn, and then it will synapse, as you can see here, in the second order neuron, and then crosses the midline, going up there to the thalamus, and here we can see the third order neuron where it goes to the cortex. You can see now the patient can suffer from pain. And if you look at the descending pathway, this pathway that is in dotted line, it goes down here, that decreases the transmission of pain here to decrease the feeling of pain. Why this is important? This is very important because people and scientists always thought about this descending pathway. Why this pathway is effective in decreasing pain. It's endogenous thing, but they start to think, how about if we have a way of activating this pathway in our human body by external stimulus such as drugs, and we selectively excite this descending pathway, so then definitely we will provide pain feeling, analgesic feeling in patients who suffer from pain. And thus, patients who suffer from pain, they will have different options of treatment. Maybe paracetamol is an analgesic that be used. Non-steroidal anti-inflammatory drugs is another class of medications, important one in the clinic, and you probably heard about them, such as ibuprofen and diclofenac and naproxen. As well as we have opioids, which is the title of this lecture. Now, as you can see here, opioids, they have another name, which are narcotics. So we will start now talking about opioids, and now we are selectively about opioids because they found that the descending pathway we talked about previously, it can activate this descending pathway, and by that way it provides a good analgesic to the patient who suffer from pain. And among all these three medications or classes of medications, opioids are the strongest, and they are reserved for very severe pain. if the patient suffers from severe pain, so then the opioids will be the first choice. Now, as I said earlier, pain can be classified into, depending on the severity, into mild, moderate, and severe. But the question is, how can we know that the patient have mild, moderate, and severe pain? Well, if anybody of the audience went to the hospital suffering from pain, usually the first thing the nurse tells the patient is that by providing a scale from 0 to 10, or sometimes they provide images from with a smiley face at the lowest and a person who cries at the most extreme, and then they ask the patient to point what feeling he suffered from pain, where 0 has no pain and 10 has the most severe pain. And once the patient point which severity of pain he suffered from, so we take that reading and we start management depending on the reading we got from that, what's called visual analog scale. So if the patient have 0, 1, 2, 3, so that's a mild kind of pain, and usually that can be treated by paracetamol or non-steroidal. Now, if the patient said like it's 4, 5, and 6, so then we can think about non-steroidal or a combination of paracetamol and non-steroidal. Now, if the patient got into 7 and above, so that is a severe kind of pain, and the drug of choice to start with is some sort of opioids. So opioids, as you can see, they are reserved for very strong pain, and they are very effective, and they are important, especially in the hospital setting, especially in patients who suffer from severe pain, such as patients with cancer, and or they have pain due to cancer chemotherapy or diabetic neuropathy, or if non-steroidal and paracetamol are not effective anymore in treating the conditions. So are very important, again, a class of medications. So let's talk about opioids in general. I will give you some historical perspective first. So opioid, originally, they came from the nature as many other drugs. And there is a specific plant in our planet here. It's called the Papaver somniferum, which is shown in the slide. It's mainly growing in South America, or grown in Afghanistan or Iran. And this plant, from time to time, it releases, as you can see here, some droplets right here, where this is active ingredient containing the active chemicals that produce some effects. In the past, before the revolution, the medical revolution in the 1900s and 1800s, even like 2,000, 3,000 years ago, they discovered this plant, and they tried to use this juice for multiple reasons. At that time, they discovered that this juice can decrease pain if it's given to patients who suffer from pain. Also, this juice was very toxic, so if it was used a lot in as toxins, if somebody want to kill an important body in the tribe, or in like an enemy, so this juice was very toxic. So it had multiple uses, and this got the interest of many scientists in the 1800s. And it was not until 1804 when there is a German scientist who got this chemical and tried to dig deep and find the active ingredient and its function, and he discovered the active chemical structure, and he called it morphine. And the word morphine came from a Latin word, or from a Latin god name, which is Morphus. There was at that time they have multiple gods, and one of the gods called Morphus, and Morphus is the god of dreams. And this juice that is taken from the plant, it produces the effect of dreaming, for example, and due to that, he called that morphine as a modification of Morphus, the god of dream. Here we can see the chemical structure, and that's when it was discovered, as I said, in 1804 by the German scientists. Now, one problem with this medication is that, first of all, it has to be taken from the nature, and it had multiple functions, and especially in pain as an analgesic or a pain medication. And another problem with this medication, besides being it has to be planted to get the active ingredient, is that they had side effects. And one side effect that I mentioned in the first slide, that these drugs may produce addiction, that the person will get addicted to it, and they will need more and more to keep himself away from any bad symptoms when they stop the medication. And they made the scientists to look for alternative for this medication. And by then, they start to discover another chemical that is taken from morphine. So they brought morphine, they added some chemical groups, acetyl groups right here and right there. And it's now shifted to another drug that's called heroin. And they thought by doing so, it will decrease the addictive component of morphine, but it will produce the same analgesic effect, and that was 1897. And everybody thought that we find the magic solution, we have the good stuff from morphine without the addictive component. But this was, as we know by now, it's a failure story, because heroin, it happened to be more addictive, because now it crosses the brain in very high rate compared to morphine, and that it produces even more addiction. So now the question comes, how can we define that this drug is an opioid or not? So opioids, we mentioned that morphine or heroin will be opioid if they bind to something called opioid receptors. So if a drug binds to something called opioid receptors, so then we call that as an opioid. And opioid receptors themselves, they are proteins on the cell membrane, just like any other receptors. And they are specifically from a G protein coupled receptor, GPCR, and they are connected to the GI inhibitory G receptors, which means once the ligand binds to the receptor and activates it, that means GI will be released in the cytoplasm, and it will produce inhibition in the targeted cell. And the mechanism by which they produce inhibition on the targeted cell is by inhibiting the calcium channels in the targeted cell, or activating potassium channels, or decreasing adenylyl cyclase function. And we can see here in this slide that this is the G protein coupled receptor, the opioid receptor. It's connected to G alpha I subunits, which this is the three subunit, alpha, beta, and gamma subunits. And upon the binding of the ligand from the outside, it will produce a change from GDP to GTP, and these subunits will be dissociated from each other. But the final outcome from this activation of these receptors is that inhibition of the calcium channels, and we know calcium are positive ions, so if they get into the cell, they produce depolarization, so they inhibit the calcium channels, and that will produce decrease in depolarization or hyperpolarization. They also go target the rectifying potassium channels, and they activate these potassium channels, and since potassium has more concentration inside the cell compared to the outside, so that will produce efflux of the potassium channels, and that will produce again hyperpolarization. They can go also to the adenylyl cyclase, and they inhibit that enzyme, and that enzyme is responsible for the production of cyclic AMP, and cyclic AMP, if it's increased in concentration in the human the cell, it will produce activation. So these opioid receptors will decrease the production of cyclic AMP, and thus all of these mechanisms will eventually produce a decrease in the activity of the targeted cell. So the next thing is that the opioid receptors that we just talked about, they were discovered not until 1973. Remember that morphine itself was discovered in early 1800s, but the receptors were discovered in 1973. And they say if that receptor is an opioid receptor, if it's bind to one of its good ligand with good affinity, which is called naloxone. So if a naloxone binds to a protein or a receptor, so we call that receptor as an opioid receptor. And when they look into the human body for these receptors, they found 3 types or subtypes of opioid receptors. We have mu opioid receptors, we have kappa opioid receptors, as we have delta opioid receptors. The presence of these opioid receptors caused researchers to think that these receptors, they are in the human body. That means we have endogenous opioids that can go and bind to these receptors. They are not there because we are waiting for somebody to discover the plant and doing synthetic drugs that can go and bind to them. So some scientists such as Hughes in 1975 discovered the endogenous opioids in 1975. And although we have 3 subtypes of opioid receptors, each one of them has its own function. We can see, for example, in the mu opioid receptor, the endogenous compound of mu opioid receptors are called endorphins. And these receptors are very important in production of analgesia, euphoria, as well as respiratory depression. We will come back to this later on, as these are the main functions of opioids such as morphine. Kappa opioid receptors, on the other hand, they have dynorphin, that's the endogenous compound that bind to the kappa opioid receptors, and they produce dysphoria, which is the opposite of euphoria. That means if they get activated, the patient will not feel very well. He will have anhedonic effect and he will not like it. And they may produce analgesia. I put that between two parentheses because a lot of research happening if they are effective. One reason they are not effective because they are associated with dysphoria. Also, they found out that activation of kappa opioid receptor may produce psychosis, and this is one big negative side effect of kappa opioid receptor agonists. Delta opioid receptors, on the other hand, their endogenous compounds are called enkephalins. They are definitely good in analgesia. However, giving exogenous compounds that activate these receptors specifically may induce seizures. So all these subtypes, again, they are called opioid receptors. That means naloxone binds to all of them. However, as we'll see later, these subtypes, some drugs can bind to some of these subtypes more or in more affinity compared to the other subtypes. Now, since the discovery of the receptors and the discovery of endogenous opioids, as well as discovery of the active ingredient of morphine and then the semi-synthetic compound heroin, there were a huge effort to find different medications that are targeting the opioid receptors without any side effects such as or especially the addictive component. And in this slide, we can see we can group or classify the opioids into different categories, such as natural, semi-synthetic, and synthetic compounds. We already know that morphine is coming from the plant that I showed previously, the opium poppy or Zahrat al-Khashkhash. And but that juice that coming from the plant also contains other chemicals such as codeine and thebaine, and all of them are naturally occurring. I gave also an example for a drug which is heroin, which is semi-synthetic, because if you look at the structure of the heroin in this chemical structure compared to the morphine, you can see that acetyl groups attached to the basic chemical structure of morphine, and that's what created the heroin. So that's why it's semi-synthetic component. And we already mentioned that the hope was it will be a lot of less addictive, but retaining the analgesic effect, and that was not true. And then they moved into synthetic compounds. So in the lab, they start to look for drugs such as methadone, and the chemical structure of methadone is right here. And we have a huge list of opioids. I'm here showing only 4 drugs, such as meperidine, or its other name is pethidine, fentanyl and pentazocine and oxycodone, and many others. So synthetic compounds, but all of them are classified as opioids. And the huge number of opioids suggests that there were a huge effort again to find medications that have the advantages of morphine without its disadvantages, especially the side effects as well as the addictive component. But unfortunately, until now, we did not have that magic drug. So let's talk about morphine specifically and see what is its effect on a human body. The major effect on human body, and that's the major indication in the clinic, is the analgesic component. And it, as I mentioned previously, opioids in general and morphine as well, as a good opioid, and the prototype of opioid is a good analgesic, and it selectively, of course, the relief of pain by acting centrally in opioid receptors in the central nervous system, and we already talked about the descending pathway. But also we have a lot of opioid receptors that are located in the peripheral nervous system, and a lot of them are located in the dorsal root ganglion and the first order neuron, and the activation of these receptors will produce also analgesic effect. Morphine at regular doses produce analgesia without producing anesthetic effect or no effect on consciousness, but at high doses, as we will see in a few slides, it may produce sedation and loss of consciousness. And opioids and morphine specifically, and other opioids as well, are better in relieving nociceptive pain rather than in neuropathic pain. So you can see that morphine and other opioids can be given, for example, in post-surgical procedures. It can be given in some post-dental procedures, severe extractions that severe pain may happen. Low back pain is another indication for prescribing opioids. But some other types of pain, they are not the first line, and the major ones are the, for example, rheumatoid arthritis. The non-steroids are the first line of therapy, as well as neuropathic pain. Opioids comes as a second line of therapy, because in the first line of therapy comes other drugs such as pregabalin and gabapentin. But if that did not work, you may think about opioids. Opioids is also the drug of choice in cancer patients and cancer-induced pain. And these opioids and morphine are usually accompanying all the cycles of chemotherapy. Opioids are well known of producing euphoria, and euphoria is a powerful sense of commitment and well-being, contentment and well-being. So, and this is the major one, the major problem of opioids, where they produce euphoric effect, and that's some patients will keep taking the medication to keep the euphoric effect of these drugs. Another thing is the production of sedation, drowsiness, or hypnosis, especially at high doses. Although you may think about this as a side effect, it could have a good effect, especially if patients are going surgery. So if a patient going surgery, it's expected to have pain, so administration of morphine is definitely indicated. But also giving or administering morphine before the surgery, it also will help in sedating the patient, and will help the anesthetist to put the patient under anesthesia quicker than if it's before morphine. So it is additive with other central nervous system depressants, and although it's, let's say, without the surgery room, if it's like a prescription outside the surgery room, a patient go home, So in that case, although it's a side effect, sedation of morphine, but the good thing is that tolerance to sedation moves too quickly compared to other effects of morphine. So probably the first couple of days, the morphine produces sedation, but in the third or fourth days, maybe the patient can keep can stay longer before he go to a sedation, or the sedation will be a little bit mild. Now, this is important because if you have a patient who is prescribed opioids, you have to tell the patient that this is a side effect, and so the patient will avoid driving or doing cognitive tasks, because that will affect his behavior and locomotor activity. One important side effect of morphine is the respiratory depression, and this is very serious, and the major cause of death in overdose is the respiratory depression. And one of the easiest way to know that this patient is under morphine or opioid effect in general is that look at the respiratory rate. If it's normally between 12 and 15 respirations per, or inspiration and exhalation per minute. So patients under overdose of morphine maybe have 3 or 4. And this is because direct inhibition of respiratory center and the brainstem, and it decreases the sensitivity of the blood of the body to the CO levels of CO2, because if there is a decrease in CO2, there is a reflex where they induce the or increase the respiratory rate, but the opioid and morphine decreases the sensitivity of the system to the CO2 levels. And as I mentioned, it's the major cause of death in the case of overdose, and that's why opioids are very dangerous. Although tolerance may develop to this also to the respiratory depression, but patients who addicted to any kind of opioid such as heroin or morphine, they take regular doses, they will get tolerance to some effects, either analgesic or euphoric effect or respiratory depression. So then they go to a higher dose, and once they reach a higher dose, so that's maybe fatal for them. And again, opioids in general have a bad lethal outcomes because of this side effect. Or morphine and some other opioids can be also used as antitussive in patients who suffer from cough, because opioids suppress the cough reflex in the medulla. Although morphine produces this effect, but there is a more safer opioid, and what that is codeine, and that's why it's more indicated in cases of cough compared to morphine. Now, another effect of opioids in general is the production of meiosis, and meiosis is the constriction of the pupils, and sometimes in the case of opioid they call it as a pinpoint. Now, I don't want you to confuse in this slide. Now here we show a normal for example, pupil the diameter and dimension here. And if you look at the bottom of the slide, this is a bilateral meiosis, and this is the effect of morphine and other opioids in human body, producing a bilateral meiosis, which is constriction of the pupils. And the opposite of meiosis is, of course, mydriasis. Now, I just put the middle picture here just to show you the difference between the pupil dimension from the right and the left. And this is not the case of opioid overdose. This is usually due to injury on one of the cranial nerves that you will study later. And but this is the opioid overdose, or even in regular doses, produce this effect. And the tolerance to meiotic effect of opioid is not happening even after a very long duration of the use of opioids. Now, the next one, and maybe 25% of patients may suffer from this effect, which is nausea and vomiting, and this is due to direct effect on an area on the brain called the chemoreceptor trigger zone, and it's a area located in the area postrema. It's like it's a central nervous system component, but it's exposed to the outside, to the bloodstream. And once chemicals in general, and opioids are one of them, if they bind to the receptors in the chemoreceptor trigger zone, they trigger the production of dopamine, and dopamine will induce the nausea and vomiting reflex, and that's why some patients cannot tolerate this medication due to these effects. Also, opioids are well known in production, in production and consistent constipation in patients. Tolerance to this effect is not is not available, such as other effects such as respiratory depression or sedation. So every time the patient take the medication, morphine for example, we will think about constipation to happen. And in such case, we always advise the patient who are prescribed with opioids to take laxatives, which are enhancing the movement of the bowels, so they will help the patient to decrease the suffer from constipation. They directly decrease the GI motility. They contract the sphincters and relax the smooth muscles other than the sphincters. So here is just a summary for what we mentioned, and there are some other effects of opioids, such as urinary retention. The opioids, morphine, can contract the sphincter, and it inhibits the reflex of urination and increase the antidiuretic hormone. In the cardiovascular system in general, they produce they produce a little bit of hypotension, and maybe at high doses they may produce bradycardia. And finally, histamine release is also well known in patients, in some patients, especially more sensitive than others. Morphine can enhance the release of histamine from the mast cell, and that may produce some allergic reactions such as urticaria, sweating, and vasodilation. Now, I want to mention here about histamine release, although we can think about some patients who could be contraindicated, such as patients with asthmatic diseases. We think about morphine is not as an absolute contraindication, but we have to be more cautious in prescribing morphine to them. This is one. And number two is that not all opioids may produce histamine release at the same level. For example, fentanyl can produce less histamine level secretion compared to morphine. So to summarize, based on all these effects, morphine can be used clinically, and the main use in clinic is analgesia. As I mentioned, post-operative pain, cancer pain, renal colic are good examples of diseases or disorders where morphine is number one choice. We can think about low back pain, some dental procedures, all of this can be prescribed opioids. In acute pulmonary edema, it decreases the anxiety. It can produce, due to its vasodilator effect, can produce pre and after, and decreases the preload and the afterload, and that will make the arteries and veins in the pulmonary circulation more wider, and that decreases the edema. Antitussive, as I mentioned, but again, codeine is usually the drug has a superiority over morphine. It can be used as a pre-anesthetic medications because of the sedative effect, as well as because of the analgesic effect, because patients will definitely suffer from pain. And finally, they can be indicated in diarrhea. And once again, morphine, although it can produce constipation and that can be helping in diarrhea, but loperamide is the drug of choice in such cases because it does not cross the central nervous system. So now let's talk about contraindications of using morphine specifically, and probably that applies to other opioids. So the first one is acute head injury. And although this is not an absolute contraindication, but the physicians usually, when a patient comes after a road traffic accident with a head injury, they prefer to delay the use of opioids for multiple reasons. First, that as we mentioned earlier, morphine decreases the respiratory rate, and that will increase the CO2 levels in the human body. And that increase of CO2 will increase the risk for intracranial pressure and they may produce herniation. Beside that, already the patient probably has head injury, will suffer from increased intracranial pressure. Also, the increase in intracranial pressure will lead to vomiting, especially in head injury. And as we mentioned also earlier, that morphine and other opioids may produce also nausea and vomiting. And finally, and that's probably more important, is that one thing happening after head injury is to assess the patient and to detect the level of injury to the brainstem or the brain or the cortex or the basal ganglia and other nuclei. And they depend a lot on some neurological reflexes and signs and symptoms, and the eye movements and the eye reflexes. All of this can be interfered when morphine is administered. So they prefer to defer or delay the administration of morphine after they finish these tests and determine exactly what are the causes or what are the level of injury in that patient. Also, morphine is also has a relative contraindication during pregnancy in two dimensions. First, if morphine is given chronically during pregnancy, that will make the child addicted to morphine, and there is a syndrome that is also as opioid baby syndrome that is associated with where opioid when he is during delivery, he may suffer from some withdrawal symptoms of opioid addiction or opioid chronic use. During delivery itself, morphine is contraindicated because it may produce uterine relaxation. So they don't prefer to use morphine. There is another opioid that has little effect on uterine in uterus during the delivery time, which is the pethidine or meperidine, but other opioids are contraindicated because of their relaxation of the uterus. Asthmatic patient, we already talked about release of histamine, but again, it's not an absolute contraindication. Patients with impaired hepatic and renal failure, and that's because morphine is metabolized in the liver and it can be excreted in the kidney. If there is a decrease in the liver and kidney functions, so then we can decrease the dose to the half or even to the quarter of the normal dose. And of course, finally, combining multiple opioids with multiple agonist activity to the receptor, that is definitely contraindicated. A good example is combining, for example, methadone with the buprenorphine. Methadone is a full agonist at the receptor, so it produces full activation of the receptor. Partial agonists such as buprenorphine will produce partial activation of the receptor. If you combine these two drugs together, that means they will compete on the receptor, so you will not get the function of methadone and you only get the function of buprenorphine, and there is no advantage of using both drugs together because you just increase the side effects without getting more effect of the methadone. Now, chronic treatment of opioids in general may produce some side effects, and the major one that we already talked in multiple occasions was the development of tolerance. And the tolerance can be fast in some of the effects of opioids, such as respiratory depression as well as sedation, where tolerance comes very quickly. In some other effects, such as constipation and meiosis, their effects or the tolerance is not developed probably at all in such patients. So even if the patient take opioids for 1 year, still the patient will suffer from constipation and meiosis. And once again, because of the constipation, always more opioids are prescribed with laxatives and change in the diet that's taken by the patient, so we decrease the risk of constipation. Also, cross tolerance between different opioids is also happening And that's why if somebody is already tolerant to one opioid, so we expect that if we shift to another opioid, tolerance will also develop to that patient. Now, the other important side effect after chronic treatment, which is dependence. And dependence is defined briefly is that continuous drug use to avoid the withdrawal symptoms. And these withdrawal symptoms can be physiological withdrawal symptoms or psychological. Physiological, where the patient may suffer from diarrhea, sweating, irritability, tachycardia, hypertension because of the activation of the sympathetic nervous system. So patients, that's the main reason why patients keep taking opioid and get addicted to that, is to avoid physiological dependence. More importantly, psychological dependence, where the patient will feel that his life is connected to opioids and he keeps seeking the drug administration from daily and more than once a day, in the case, for example, heroin, and that will produce eventually the addiction. So in this slide, we are showing the different opioids that are already used in clinic, and still we have more drugs that are not here as well. Meperidine or pethidine is used sometimes. We said it is preferred during pregnancy because it has the least effect on the uterine contraction, in the uterine relaxation. So it does not produce relaxation such as morphine. It also has less effect on pupils, so it does not produce meiosis. We already talked about heroin. Heroin now it's scheduled as Schedule 1, where it has no clinical advantage and it is not prescribed clinically. Methadone is a very potent and very efficacious opioid. It is used for opioid detoxification. And the meaning of opioid detoxification is that the drug that is used for patients who are seeking treatment of opioid addiction. If a patient comes to the hospital asking for help to stop addicting heroin, and heroin is taken by IV, so methadone is the drug of choice, and methadone is taken orally. So giving a drug orally compared to giving it as as IV. So in that case, that is a good advantage of giving the drug, because we avoid any transmitted diseases through bad syringes. Also, methadone compared to heroin has a longer duration of action, is around like 2 days, 48 hours. So the patient needs every 2 days one pill. In heroin case, the patient will need heroin every 4 to 6 hours, and that will increase the risk as well for infections and more cost. So methadone is a drug of choice in case of opioid detoxification. Fentanyl is one of the most potent medications, or one of the most potent opioids. It is used either in two ways. It's used during in the theater or surgery room before the general anesthesia, so it helps in sedating the patient as well as providing a good analgesia. But also it can be given to patients outside the hospital, where it can be given as a patch. We don't like to give fentanyl as a powder because, again, it's very potent, so any increase in the dose may produce a lethal effect, especially in respiratory depression. Remifentanil is it has a very duration of action, and it's used also in the before the surgery. Oxycodone and hydrocodone, probably oxycodone is available in Jordan, but it's more common in other countries, oxycodone, hydrocodone, and these are drugs that are given by tablets and prescribed commonly. And here I want to advise you to watch a series of episodes on Netflix called The Pharmacist. It shows how the abuse of prescribing oxycodone and hydrocodone may lead to serious side effects, not at the individual, but as well as at the community level. And it is a very good series, and it will give you an idea the importance of these medications. Codeine, also we talked about it. It's one of the natural natural opioids, and it's mainly used as antitussive. These drugs are full agonists. Now we have some partial agonists. We have pentazocine, we have buprenorphine, as well as we have nalbuphine. Nalbuphine is used during labor pain, used during delivery. It has a low effect um, on the delivery during the process of delivering the baby on the uterus, but it can provide some good pain relief to the mother during delivery. Buprenorphine is another drug that was indicated after methadone for opioid detoxification. So it also can be given to patients to stop addicting heroin. Now, one thing about the buprenorphine, when it's given to patients, it's given by combining it with naloxone, and we mentioned earlier that naloxone is an antagonist to the opioid receptors. We give both drugs together, and I want you to think why buprenorphine is given with naloxone in oral tablets. Why we give a partial agonist with antagonist where they compete on the receptor for patients to help them to stop heroin addiction. So please think about it and write that either by the comment or email that to me. Antagonists, naloxone is the prototype, and it is the drug of choice in case of opioid overdose. If a patient has a cardiovascular problem, severe meiosis, has very, very low respiratory rate, and if you hear the GI sound, there is no GI sound, so you think about overdose of some sort of opioid, so naloxone is the drug of choice. Naltrexone is another drug. It has a longer duration of action compared to naloxone, and the good thing about naltrexone that it is indicated for alcohol dependence. So alcoholics can be treated by prescribing naltrexone. So this is just a summary for the clinical advantage of different opioids for analgesia and for cough suppression and for antidiarrheal effect anesthesia and for the opioid dependence. Methadone as well as buprenorphine are two drugs of choice in such condition. Opioid overdose, naloxone or naltrexone. Now please remember that naloxone has a short duration of action, so if the patient is under overdose, so sometimes we may need multiple injections of naloxone to save the patient's life. Here I want to talk about two other medications that are also used widely. The first one is a tramadol or tramal. Although it targets the mu opioid receptor, but also it can attack or it can work through different other mechanisms such as serotonin and norepinephrine reuptake inhibitor. So it has multiple mechanisms of action. And they think that this drug may have less abuse by liability or abuse production compared to other opioids. There is multiple studies proving that it may produce abuse, but it is less compared to other opioids, but also it may provide a good analgesia, especially in the emergency room. The other drug I want you to know is a drug called oliceridine, which is a very new drug that is under the category of biased agonist. And you should know what is biased agonist by now, where the drug can activate one second messenger and inhibit other second messenger. It is also thought it has this abuse potential, but again, this was not proven until now. With that, I would like to thank you for your time, and I hope you enjoyed the lecture. Good luck.